Thank you for the kind introduction. Honored to be on the panel with our colleagues. And I've been fortunate enough to be involved with the cryoballoon probably since its animal study stage with CryoCast. So seeing its recent approval for the persistent atrial fibrillation and seeing how it has affected our AFib population really is being very rewarding. Overall, this has really taken over our practice for atrial fibrillation ablation. And I'm looking forward to the ongoing discussion tonight with Dr. Calkins and Dr. Reddy.
I'm Vivek Reddy. I too am also very much looking forward to this discussion. You know, it's interesting. Our field is a very dynamic field with it's very technology oriented. At the same time, there are a number of technologies that don't quite make it for different reasons, and it's striking how well the cryoballoon has performed and how effective and safe it has turned out to be. I remember the first cases that we did back in 2004. It was quite a, I'm not sure even I saw how big and how impactful it would be in the field. So I think it's really sort of, it's very nice to see where it's developed. And so I think I'm really happy and excited to be part of this next stage in its evolution.
And I'm Hugh Calkins. As you've heard, again, I'm very pleased to be part of this team. I was pleased to be part of the persistent ablation trial, which was just published. You're going to hear more about that tonight. And I'm a great fan of the cryoablation system as a way to achieve effective pulmonary vein isolation, which is extremely important for our patients with atrial fibrillation. So my talk, I'm going to kick this thing off, and I'm going to talk a little bit about the rationale behind pulmonary vein isolation for treatment of persistent AFib, and my disclosures are shown on this slide. Now, I think first I think it's important to sort of think about the different types of AFib. Paroxysmal AFib is now defined as AFib that lasts for less than 7 days. Persistent AFib is AFib that lasts more than 7 days and less than a year. Long-standing or long-lasting persistent AFib is continuous AFib lasting more than a year or more than 12 months. And then permanent AFib is really a management strategy. When you and the patient decide not to pursue a rhythm control strategy, you can refer to a patient as permanent AFib. It doesn't mean their AFib is really permanent, because I'm sure any of our panelists tonight probably could ablate that AFib, but it means that the patient may be asymptomatic or minimally symptomatic, and together you've chosen not to pursue a rhythm control option. Now, I think we all appreciate that patients with AFib generally present first with paroxysmal AFib, and over a variable period of time, they'll progress to persistent AFib, and there's various studies that talk about rates of progression. And then when someone has persistent AFib over time, that can evolve into long-standing persistent AFib. So AFib is a progressive condition. It's a little bit variable in its clinical course. Some patients first present with persistent AFib when you first meet them, but it's generally a progressive disease. And I think we all appreciate that the longer you're in AFib, the harder it is to get a patient out of AFib. If I see a patient in clinic and they've been in AFib for 5 years and the left atrial size is 6 centimeters, there's almost nothing we can do to get them back to sinus rhythm. That compares to a patient with paroxysmal AFib, where we obviously get the best results of both catheter ablation and also antiarrhythmic drug therapy. Persistence in between, long-standing persistent AFib, it becomes a bit more of a challenge. Now, if we think about the success rates of catheter ablation of atrial fibrillation, clearly the best results are in paroxysmal patients. And if you sort of think about the patients we see, you can have the perfect patient, a 50-year-old thin patient with no other comorbidities with paroxysmal AFib. All of us love that kind of patient for AFib ablation. And then you have other patients that may have sleep apnea, obesity, other conditions, but their AFib still paroxysmal. That's still going to be a pretty easy ablation. And when you get into persistent and particularly long-standing persistent AFib, success rates fall, by 20 to 30%, as shown, in this slide. And I think we all appreciate that. And when we have this discussion with a patient about success rates, this clearly factors in a major way to our discussion. Now, we've talked a little bit about AFib being progressive, and I think everyone in the world, there's general understanding that in early forms of AFib, the trigger is the important thing. There's very little substrate. And when I talk about substrate, we're talking about fibrosis, left atrial dilation, and that over time, the remodeling of the structural changes occur. So in patients with paroxysmal AFib, it's mainly triggers, and most triggers come from the pulmonary veins. As you move into persistent forms of AFib, you get age and morbidity-related remodeling and also AFib-related remodeling, and the atrium starts to stretch. There's more scar. There's more room for rotors or, reentry or whatever to occur. And then again, when you've been in long-standing persistent AFib for years, there's oftentimes extensive remodeling. And I think all of us have seen that patient where you bring them in for an AFib ablation and they have a monster atrium, 8 centimeters, sort of spherical atrium. And I think we all appreciate that that's a patient, the chances are things aren't going to work out too well from a success rate. Whereas someone with a nice, compact, small atrium, that's obviously what gets us, happiest when we do these procedures. When we think about the substrate for AFib, I think there's the greatest preponderance of evidence that support the importance of the pulmonary veins. And I think all of us, remember that the group in Bordeaux back in 1998, when they published their seminal paper in the New England Journal of Medicine describing pulmonary vein triggers for atrial fibrillation, that really refocused all of us on the pulmonary veins. That observation and all of our cumulative experience over the last many decades have made us appreciate how critical the pulmonary veins are to the initiation and perpetuation of atrial fibrillation. And this is the reason when we published the first consensus document in 2007, and Vivek was part of that team, we put in there that pulmonary vein isolation is the cornerstone of AF ablation. And that's as true today as it was in 2007. This statement continued in 2012 consensus document and also in the 2017 consensus document. Now, because as AFib progresses, I think most of us believe there's more to AFib in those patients than the pulmonary veins. There's more other substrate outside the pulmonary veins. We all have a sense that we need to do more. The question is, what is the more? If you look at the 2012 consensus document, we said, operators should consider more extensive ablation based on linear lesions or complex fractionated electrograms in addition to PVI. We sort of had this soft statement. That was a time when many in the world were really excited about cafe ablation or ablation of these complex fractionated electrograms, ablating determination of AFib. Of course, that has subsequently proved to be of little to no value, but that's what we said, at that time. Now, if you look at the studies that have been done since then, comparing pulmonary vein isolation versus pulmonary vein isolation plus something more, I think the STAR-AF2 study is probably the one that that got the most sort of attention. The STAR-AF2 study took patients with AFib, persistent AFib, and randomized them to pulmonary vein isolation plus lines, or pulmonary vein isolation and cafes, complex fractionated electrograms. And everyone at that time assumed that, of course, lines or cafes are going to win. The more you do, the better you do. And guess what? PV isolation alone actually tended to have a better efficacy than all these additional lesion sets that added time, they increased complication rates. And again, if you look at this slide, which sort of summarizes some of the studies that have been done, they sort of show that more is not actually better. For most patients, takes longer, more complications, but the data is saying we're actually improving outcomes is really 0 to none. This is just some more studies that were done, again, looking at PVI. Now, I think we all also appreciate the importance of second procedures. You have single procedure success rates, and then you have success rates with multiple procedures. And if you do multiple procedures and you use antiarrhythmic drugs, you can control AFib in more and more patients, and that's what this study speaks to. But the additional targets, cafes, lines, again, added little to nothing to these ablation strategies. So at the end of the day, we come back to this sort of constant observation of the importance of pulmonary veins. Most triggers come from the pulmonary veins, 90+%. And this is really why at the end of the day, we come back to we really need to start with pulmonary vein isolation, do pulmonary vein isolation as safely and as effectively and quickly as possible. And that's really where we are today. And again, there's many, many studies that show that pulmonary vein isolation is of value both in paroxysmal, but also growing evidence showing its value in persistent AFib. And we're going to hear about more of that tonight. So anyhow, if you look at the latest consensus document that we put together in 2017, we continue to say that pulmonary vein isolation remains the cornerstone for all AFib ablation procedures. And then for all the other lines, all the other strategies, lines, cafes, non-pulmonary vein triggers, all of them get a 2B indication, meaning you can consider performing them, but the level of evidence that they do anything good is next to nothing. And we really encourage patients to be in clinical trials if you're planning to do more than PV isolation. So at the end of the day, what's shown in panel A, pulmonary vein isolation alone, really has the greatest amount of scientific data supporting its value in adding lines of all types and ablating non-pulmonary vein triggers. Really, these studies have come up a little bit empty, and these remain, in my mind, largely an investigational approach. Those patients should be put in clinical trials. So with that, I'm going to stop, and I'm going to pass it on to my colleague and friend, Vivek Reddy, who's going to present the results of the Stop Persistent AFib trial. Vivek, I'll turn it over to you.
Thank you very much, Hugh. So I'm really pleased to be able to present the results of the Stop Persistent AF clinical trial. This was an FDA clinical trial. I should note that, let's see here. I should note before I start that I do have a conflict of interest. I'm a consultant to Medtronic, who's the sponsor of this clinical trial. So this slide, you see the various steering committee and the event review committee, as well as the various investigators who participated in the trial. They're investigators from the United States, from Canada, as well as Japan, who participated in this effort. The trial was funded by Medtronic, and there were reference materials that were requested and obtained from Medtronic for portions of this presentation. I should also note that the data analyses have been reviewed and approved by the US FDA. So first, let's look at what exactly this study tried to assess. So if we look at the primary efficacy and safety endpoints, the primary efficacy endpoint was to achieve success at 12 months, and there was a performance goal of over 40%, and we'll get to the details of that. In order to achieve success, each patient had to achieve 3 different aspects. The first was acute procedural success using the cryoballoon catheter only, and that was PV isolation. Second, freedom from any atrial arrhythmia recurrence, AFib, atrial tachycardia, or atrial flutter that exceeded 30 seconds beyond the 90-day blanking period. And third, no increase or initiation of a new class 1 or class 3 antiarrhythmic drug after the 90-day blanking period. The primary safety endpoint also had a performance goal of 13% of the upper confidence interval. We'll get to the details of that. The primary safety composite included both acute procedure-related events, as you see there, within 7 days, including certainly mortality, cerebrovascular accidents, including TIAs, major bleeding requiring transfusion, myocardial infarction, pericardial tamponade, and pericardial effusion. It also included other ablation-related events that could occur late, such as PV stenosis or atrioesophageal fistula any time over the course of the trial, or a phrenic nerve injury that was unresolved by the 1-year time point. And there were also quality of life secondary endpoints, including the AFEQ2 and the SF12 questionnaire that were obtained pre-procedure at baseline at 6 months and at 12 months. This is the trial design. This was a prospective, multi-center, single-arm study with these predefined performance goals. There were a total of 20 sites across the US, Canada, and Japan. The approach was to use a PVI-only strategy using the Arctic Front Advanced Cryoballoon catheter. If a radiofrequency ablation catheter was used in the left atrium, that was considered a primary endpoint failure. For PVI isolation, PVI touch-up was permitted using the Freezer Max catheter. We should note that patients were encouraged to discontinue antiarrhythmic drugs by the end of the 90-day blanking period. The follow-up you see below in this chart, all patients were required to submit weekly as well as symptomatic transtelephonic ECG monitoring, starting at the three-month time point and continuing through the 12-month follow-up period. Patients also had an in-office 12-lead EKG at 3 months, 6 months, and 12 months, as well as 24-hour Holters at 6 months and 12 months. And the quality of life surveys were administered, again, pre-procedure at 6 months and at 12 months. These are the key inclusion criteria. Patients were required to have symptomatic persistent AFib of at least 7 days duration, but not exceeding 6 months duration. Patients should have failed an antiarrhythmic drug, and they should be adults over the age of 18. Important exclusion criteria included any prior left atrial ablation, whether catheter or surgical based, a cerebrovascular accident within the 6 months prior to enrollment, a depressed ejection fraction less than 35%, or a left atrium dilated to beyond 5 centimeters in the anterior posterior dimension. So if we look at the patient flow, there were a total of 186 patients that were initially enrolled. Of those, 21 were exited prior to the procedure for various reasons. You see that 10 patients didn't meet the inclusion and exclusion criteria. 6 were exited for other reasons, and 1 patient was lost to follow-up. So ultimately, that left 165 patients that received the cryoballoon ablation procedure. After the ablation procedure, some patients did exit. You can see 20 exited, 6 were lost to follow-up, 6 requested withdrawal, and 8 for other reasons. So ultimately, 145 patients completed 12-month follow-up required in this study. So if we look at the patient demographics, we see that it was male predominant at 70%. The mean age was 65 with a left atrial diameter of 4.2 mean centimeters. The overall ejection fraction was 57%. You can see that many of these patients had paroxysmal atrial fibrillation before their persistent atrial fibrillation. The year since PAF onset was mean of 5.1 years. The years of persistent AF onset was a mean of 0.6 years, and the duration of the most recent episode was 60 days. The duration of the longest episode was a mean of 72 days. The mean number of drugs that these patients failed was 1.2. About 3/4 of the patients had a cardioversion prior to enrollment, and the mean number of cardioversions per patient was 1.9. 17% of the patients had a history of atrial flutter, and you see the BMI, the mean BMI was 31. Now, if we look at the follow-up, the compliance was actually quite reasonable. There was 96% compliance with the office visits and the 6-week phone call. And the weekly transtelephonic monitoring had a compliance of 73%. So let's look at the outcome. So this is the primary efficacy endpoint. And you see on the Kaplan-Meier curve, after the 30-day blanking period, you see the point estimate here in this line, as well as the 95% confidence intervals. Importantly, the lower bound of the 95% confidence interval exceeded the 40% performance goal. So this did meet the criteria with a p-value of less than 0.001. Now, if we look at the patients that didn't meet the efficacy endpoint, you can see the different reasons. Only 1 patient failed acutely, meaning that not all of the veins were isolated with the cryoballoon alone. 2 patients had RF ablation during the blanking period, and 59 patients had recurrence, usually because of atrial fibrillation, though 9 patients had recurrence because of atrial flutter. 10 patients failed because of an increase of arrhythmic drugs beyond the 90-day blanking period. Here's the primary safety endpoint. Again, if we look at the Kaplan-Meier curve, you see the point estimate line that's in dark blue, and these are the 95% confidence intervals. And you can see the upper bound of the 95% confidence interval still was far below the 13% performance goal. So again, this did meet the criteria for to declare success for this primary safety endpoint. Now, what was the primary safety endpoint? It turned out there were no cerebrovascular accidents, myocardial infarctions, tamponades, or PV stenosis, or unresolved phrenic nerve injury. There was one patient who had cardiac perforation. Interestingly, this occurred in a patient not at the time of the index cryoballoon procedure, but rather during a repeat ablation procedure that was intended to be a radiofrequency ablation procedure. During that procedure, near the beginning, at the time of the transeptal puncture, there was inadvertent puncture into the aortic root, and hence the procedure was terminated. Let's look at other serious adverse events, and you see the list here. In the left column, we see cryoballoon-related major adverse events, and on the right, just procedure-related major adverse events. So if we go to this list, there was one patient who had atrial tachycardia, one with pericarditis, 2 with vascular pseudoaneurysms. There was one patient who had heart failure that was thought to be procedure-related, not cryoballoon-related, one patient with post-op ileus. There was one patient with the puncture site hematoma, and one patient each with respiratory distress or urinary tract infection. Let's look at the procedural characteristics. The mean procedure time, total procedure time, was just around 2 hours, with the left atrial dwell time a mean of 102 minutes. The study device left atrial dwell time, that is the amount of time the cryoballoon was in the left atrium, was just over 1 hour. The total fluoroscopy time was 19 minutes, and the cryoapplication duration time was 24 minutes. This is the secondary endpoint, which is quality of life. If we look at the AFEQ2 score, you can see that as compared to baseline, there was a significant improvement in quality of life that was maintained out to the 12-month time point. Now, if we look at this improvement, there was about a 26-point improvement. Is that good? Well, it turns out, yes. A clinically meaningful threshold is at least an improvement of 19 points. And again, there was this 26-point improvement. Using the SF-12 score, again, there were improvements in both the mental health in red and the physical health in blue. From baseline to 6 months, again, maintained out to 12 months. If you look at a clinical meaningful threshold of 5 points, you can see the improvements for both the mental and physical are just about 5 points each. If we look at patient-reported symptoms as compared to baseline in the dark bar, you can see for all of these various symptoms, there was significant decrease between baseline and the 12-month time point. The other interesting outcome was if we look at freedom from repeat ablation, it was actually quite impressive. You can see that only about just over 13% of the patients underwent a second procedure. So despite the fact that many patients had at least one AF recurrence and follow-up, they appeared not to have been significant enough to warrant a second procedure, at least over this 12-month time point. So in conclusion, the STOP Persistent AF trial was an FDA-regulated, multi-center prospective evaluation of the cryoballoon employed for PVI only in patients with persistent AF, and it achieved both the safety and efficacy primary objectives. Again, the primary safety endpoint rate was 0.6%, with the upper confidence bound well below the pre-specified performance goal. Similarly, the primary efficacy endpoint was 55%, with the lower confidence bound that exceeded the pre-specified performance goal. And both of these did meet their criteria to declare success. Also, important secondary endpoints, the cryoballoon strategy did improve quality of life and reduce patient symptoms with a high rate of freedom from repeat ablation. So with that, I'd like to turn this over to Wilber for him to take this to the next step of how we apply this to our clinical practice.
Well, thank you, Dr. Reddy. Thank you, Dr. Calkins, for the excellent overview of how we have come about to treat atrial fibrillation. And a lot of data has been thrown at us in terms of what persistent AFib ablation is about and how we go about treating with ablation strategies. And in persistent AFib, this is a first FDA monitored trial that led to the approval of this product for the early persistent AFib. But many publications has come out before then to really look at the success rate. And even though the designs and methods of monitoring vary, it's actually a fairly consistent outcome in terms of what we see across the different publications. So over the years of watching how the cryoballoon has taken over how we do paroxysmal atrial fibrillation, and now the early persistent atrial fibrillation, I think many operators have recognized that this really is a very safe and efficient procedure. It has, as the data have shown, that the major complication has drastically reduced and very predictive patient outcome. And essentially, it becomes a very much a same-day procedure even in many centers. And looking at how this really has become the new standards of how we do ablation and treat the AFib patients. And I think the focus here is really to look at the value of how we compare this to what we traditionally have done ablation. So models looking at the value of cryoballoon versus radiofrequency ablation has really looked at not only the primary outcome of success and freedom from atrial fibrillation, but also on the procedure itself, and as well as the need for repeat ablations, and of course the safety aspect of this. So without going through any more other data, I think the most important part is looking at what we know so far and see how this really can apply and affect what we do. So I like to bring Dr. Calkins, Dr. Reddy back and ask for your opinion about what we just have learned about the early persistent AFib with cryoballoon and how this may affect your practice. Dr. Calkins, what do you think your main takeaway is?
Well, I think the results of this study support how my practice has evolved. And now I'm a great proponent of using the cryoballoon to isolate the pulmonary veins as the first procedure for both paroxysmal and also early persistent AFib patients. I mean, the procedure, as you saw in this study, is remarkably safe. That's very consistent with my experience. It's very predictable. We can get home, get 2-3 cases done in a day, and the efficacy is excellent. The development of left atrial flutters, tamponade, all seem to be less with the cryoballoon. So I become a big proponent for this. If someone's coming back for a second procedure, that's different, and maybe we'll talk about that a little bit later. But for a first procedure, in my mind, you start with the pulmonary veins. That's job one. And yes, the patient may come back and may need more. But why not wait to do that with a second procedure? If you do it with a first procedure, you're going to cause more complications, take more time, and there's very little scientific underpinning for those strategies. In my mind, they should be in a clinical trial. So I thought this was an excellent study that really, it's not going to change my practice. It's just going to support my practice as it's evolved. And I'm not surprised by the results. And I think it's an important study that for those that aren't using this approach, it's certainly worth them considering it, because I certainly have found it. And Wilber, you're one of the real pioneers and early advocates of the cryoballoon approach. And I have to say that I've followed your path here, and I think you're right on this one.
So I think, as you mentioned, a lot of what we see is important. Now, patients come to us in the office and they often ask, well, what is your success rate? And I think the patient over time have also gotten a lot wiser and really look at the importance of safety of the procedure. So I think that what led me to go with cryoballoon versus the RF PVI, when we starting from the animal trials to early patient experiences, it's really a night and day difference for me from what I saw. So that kind of led me down the path of using cryoballoon for PVI. And now that with the added evidence of using this for early persistent patients, just really expands what I can tell patients. That's why we're focusing on the PVI procedure right off the bat. So Dr. Reddy, what do you think this has changed in terms of how this has changed your approach to AFib patients?
Well, I think that, what Hugh said is true. There's, as oftentimes happens when it takes a long time for a clinical trial to be performed for a particular indication, the field moves beyond. And I think many people have been already using the cryoballoon for persistent AFib. There have obviously been a number of single-center studies that have been published on the efficacy of PVI alone with the cryoballoon for persistent AF. But I think it was actually very important to have a properly controlled multi-center FDA trial, which is really, I think, the right way to compare to other technologies and techniques, et cetera. So yeah, I think that this probably buttresses a lot of people's opinions and perhaps just sort of fortifies the practice that many people are already doing. The other important point, I think, that Hugh and I think you also, Wilber, touched on is the issue of the relative reproducibility of the procedure with this system. So what you oftentimes see is that when you look at the point estimates, for example, in procedure time or whatever, the standard deviations tend not to be that wide because it is reasonably reproducible. So obviously there's always some difficult cases here and there, but the point is it tends to be relatively reproducible. And I think that does certainly help with the workflow of the lab.
Yeah, that is very critical. I think not only the reproducibility and the workflow, I think our staff are very happy to have a full day of cryoballoon because it's very predictable. And as I look at how every center does the workflow, have the workflow on AFib ablation around the world, what's very impressive is also different operators. We proctor different cases from RF to cryo, and it's very striking difference when you look at the experienced and inexperienced operator when it comes to radiofrequency ablation. I can think back, what I did first 500 ablation for RF PVI is really different than my, latter 500. For cryoballoon, I can go and teach a novice in cryoballoon ablation after 10 cases. I think they're doing just as well as many experienced operators. But I think that's a huge component of having a technology that's reproducible for every patient they come to. Right? So I think that's a huge advantage of cryoballoon system. Have the single shot, repeatable, reproducible, and really very elegant way to do the PVI.
Yeah, I think, Wilber, I think you're right about the learning curve for RF. I mean, the technical skills, this is sort of as you say, I would agree that very quickly you get up your learning curve and you're getting very consistent, reproducible results. With RF, someone that's done thousands and thousands is going to do better and faster and whatever than someone's on their learning curve, which may take hundreds of cases to get there. I mean, it's clearly, I think none of us think RF doesn't play a role in this, but for us, it's more for redo procedures where we're thinking about RF for patients with a atypical flutter or right-sided flutter. That's where I think the RF becomes important.
That brings up a very important point. So when we see a patient in clinic and we decide how to approach this patient, we often already have our mindset on what tool set to use. So this certainly helps with the knowledge base of what we can tell patients who are early persistent AFib and while we're doing cryoballoon first and what the expected outcome can be. Now, some of the labs I see around the world do consistently think about doing a right-sided flutter line, whether they or not they may have a flutter. Is that something you do?
Well, I mean, Wilber, I'm a great believer in the consensus document, and the consensus document very clearly states you should only do a right flutter line if you have had prior typical flutter documented on a 12 lead, or you have inducible flutter at the time of the ablation procedure. And I think that's true. I think to put in an empiric line, I don't think we have evidence to say it has value, and I think it adds time, risk, and expense. So that's not a strategy that I adhere to. I follow the consensus document and limit it to patients where there is documented or inducible flutter.
Dr. Reddy, what about you? What's your typical approach?
Well, I think it's always important to weigh the benefits and so the risks of anything that one does. So, for example, if you're doing an ablation with a balloon ablation catheter like the cryoballoon, then in order to do a flutter line, you'd have to open up another catheter, which adds expense. And it does add some complexity depending on whether or not you could have a mapping system with that catheter or whatever. So I think that it's a higher bar in terms of whether or not you should do that line. And perhaps in that kind of a situation, it makes more sense to say, well, you do it in people who documented flutter or inducible flutter. Yeah. Now, if you're doing an ablation procedure and with, let's say with radiofrequency energy, for example, a point ablation catheter, so you don't have to open up another device, then I think I can see how one could go both ways. So in our trial, for example, the recurrence of flutter and follow-up was only around 5%. It was actually quite small. And by the way, we don't know if that was typical flutter. Some of them could have been atypical flutter, in which case a CTI line would have zero benefit. So in that sense, in that situation, the question is, does it make sense to do a typical flutter line in everybody to help to improve your success potentially by up to 5%? And I think everybody will come out to a different answer. If it's a relatively quick procedure, you're not opening up another catheter, I can easily see doing that, which we oftentimes do. Or I could say, well, it's only 5%. Let's not add the complexity. There's always a risk with everything you do. I can see reasonable people going either way.
I think we've seen the evolution of AFib ablation over the past 20 years, and I see a pendulum kind of swing back a lot more. I remember the days where we ablated AFib until it terminated, and put every line possible in there. And, then we, looking at the complication rates, I think we forget that, first do no harm. But now with the tools that's available, which is, number one, safe, and number two, being effective in what it does in getting the PVI done quickly, I think that's really how it has taken over most practices. I think I see centers that empirically putting flutter line all the time, and that's why they choose one technology versus the other. And I think it's time to maybe rethink about how they approach the persistent AFibs. Just concentrating on the high yield areas, because inevitably we always remember the cases where the cable tricuspid line may take longer than the PVI, and at the end of the day, it may not even be successful, and end up having a secondary flutters after that. So I think in summary, we'll conclude that this is the cryoballoon ablation has come a long way. It's now the first and only FDA-approved catheter for the treatment of persistent atrial fibrillation. And this really reinforces the PVI is the cornerstone of all AFib ablations. It is a safe, effective, and very efficient way of treating drug-refractory persistent atrial fibrillation, and most importantly, improves the quality of life for our patients. I think I'll end right here and take any questions.